Hello, good afternoon. Welcome to the Demonstrating Implementation Excellence stream of SNOMED Expo 2023. My name is Alejandro Lopez Osornio. I'm the Senior Implementation Specialist in SNOMED International. I will be moderating today's session. All questions will be answered at the conclusion of the presentation. Online attendees, please use the QA button to type the questions to the presenter. On-site attendees, please use the microphone provided in the center of the room. I'm now pleased to introduce Monica Jones from Animo Consultancy Ltd, who will be presenting Implementing SNOMED CT at the national level, the Jamaican journey. Monica, please go ahead.
Thanks very much indeed. And thanks everyone for coming today, and thanks to everybody who's online, whoever you are. I'm delighted that I've actually got a couple of colleagues here today, Dr. Keisha Barwise from Jamaica and Heather Grain from Australia, but also fellow director from Gecko. So my partner always says when I'm preparing these things, it's not all about you, Monica. I went, really? So yeah, I've just put a little slide in all about me. So yeah, so it's really to sort of demonstrate how did I get to this point? How am I talking about sort of Jamaica and implementing sort of SNOMED? But essentially, sort of Animo Consultancy is my company, and it's been in existence since 2006, and it's really sort of about wanting to share experience, upskilling. I'm an educator. I am also just happen to be the Chief Data Officer at the University of Leeds in England. But I worked for the NHS for many years, and actually sort of worked at the front line with SNOMED, sort of warts and all, and Lele's smiling at me here because she and I worked at the same trust, although at different sort of times. But it's actually really wanting to take that experience and move things on. So obviously, as an educator, we want to know what the learning outcomes of this will be, but what I'm trying to tell you today, and I haven't got loads of slides, because actually sometimes it's just nice not to have to rush through these things. So the aim is to whet your appetite. I'm around for the rest of the conference and actually into the weekend, as is, and Keisha and Heather are here until tomorrow as well. But we really want to try and explain sort of, where do you start from scratch? How do you actually, at a national level, how do you prepare yourself for it? So what I'm trying to do, and there's also lots of lovely pictures of Jamaica because it is so gorgeous. Of course, when the contract started for this, it was just as COVID hit. So all of those wonderful plans of going out to work with colleagues in Jamaica was like, we're online. So we did eventually get there last year and again, sort of earlier this year. But really what I want to do is sort of, use this example to say, what is the experience? How do you start? What's the to-do list in order to be able to be both a national member of SNOMED International, but also how do you actually, particularly as a small country, such as Jamaica, and no sort of immediate neighbors who have sort of tackled these things, how do you work at it? So how did we get involved? And that was really, so the PAHO and WHO sort of established the frameworks, and you mentioned sort of earlier the information skills for health, which includes sort of integration systems. So that was essentially the reference model and the 4 component parts of that the Jamaican government, and particularly the Ministry of Health and Wellness, back in 2016 said this is the right way to do it. We want to bring sort of governance and structure. We want to get it right first time. We don't, we are, because you've got the advantage almost of starting from a greenfield site and actually not having all of that sort of legacy of digital systems. How can we sort of leapfrog really above other people in order to do the implementation? And also, if you're not a particularly wealthy country and you haven't got that sort of funding, government funding that actually can pump prime this, how can we sort of leverage the sort of the national and the international help in order to do that? But what they also recognized under the leadership of Dr. Michelle Roof, who had the vision, she really sort of got it, and has spent the last 7 years really trying to persuade people that this was the right thing to do. So she reached out to us through the Global E-Health Collaborative, and basically said, can you provide us some consultancy in order to be able to get us to the right place? So it's been predominantly about education, about training, working and developing with colleagues. And I always say I take the Nanny McPhee approach to these kind of things, that when you need me but you don't want me, then I'll stay. When you want me but you don't need me, then I'll go. So we sort of became hands-off in sort of March this year, and the Jamaicans are continuing to go from strength to strength. So people in the room or people online might not know what open EHR, or open air as it's sometimes referred to, it actually sort of is. So I just wanted to put a couple of slides in here. So I'm not just talking about SNOMED here, I'm talking about open EHR, I'm talking about FHIR, I'm talking about bringing all of the appropriate sort of open standards together in order to be able to achieve the best results at a national level. And I particularly like this diagram. It's produced by EY, so I will check, sort of name check them. But actually it shows, I think really clearly that if you put the data layer at the center rather than having lots of different sort of layers, your chance of sort of interoperability and building up on those sort of logical units to then ultimately be able to plug and play your various applications and your ability to use things is a much better model. And it's all about separating the data from the applications. Many of us here will have seen some horrendous sort of implementations of sort of clinical systems where everything is tremendously proprietary. It's embedded within the system. You haven't even a clue whether they've got a sort of a logical model or an information model, never mind actually how that sort of relates to standards. So this is very much about visibility, and it's about opening it up. And this is a very simplistic sort of slide, but it's one I wrote for a strategic committee meeting in 2020 that actually sort of, I just tried to, say bit by bit, what are the advantages of using a sort of an open EHR sort of approach. But it is very much about sort of joining things up. It does have safety at the center of it, because the pushback sometimes is, oh, well, it's not sort of, that FDA sort of accredited system, oh, how can I trust it? Is it safe? Is it clinically safe? But the amount of effort that has been put into this over the years, it has definitely moved from, what was originally a sort of an academic exercise into a truly sort of, safe and deployable approach to developing electronic patient records. Inevitably, it is a cheaper approach, and something that you can build in sort of incrementally. But just like SNOMED, it's built by clinicians for clinicians, so it has that sort of real sort of understanding, and it's easy to use, and it gives you back control. So the Jamaican journey, we sort of set off on this path in 2020. And we realized there were component parts that we needed to tackle. And one of the big things was identity management. And, we were hit at the same time by a global pandemic and sort of not having any kind of electronic sort of patient index in order to even be able to do sort of COVID reporting, never mind actually with the sort of more strategic development of the digital health sort of systems. So that was something that definitely needed to be tackled up front. We recognized also that we then needed to look at sort of the vocabularies, and you can see the sort of component parts there, to the information modeling and the information exchange, so that we can ultimately get to one source of the truth. And this is essentially how we did it. There was a whole lot of paper out there, and there is still a bit of paper, and many of us will be familiar sort of with this, and it's the mistake also people have made in the past is just taking the paper and turning it into an electronic form and going, there you go, you're digital now. I don't think so. So actually being able to build archetypes and having a common data repository, and actually then creating the value sets and the ref sets, sort of using SNOMED and using FHIR, is the approach that we'd sort of taken. I have to admit, though, that when we did actually sort of go out on a visit, and one of the photographs that was there earlier, we went to the comprehensive clinic in Kingston, which is sort of I thought, oh, this is equivalent of our GP practice in the UK. No, it's comprehensive is comprehensive. You know, it literally is from sort of, you know, stab wounds to sexual health, and everything in between. But actually, what an amazing sort of, you know, facility. And we went into the records office to be met by Miss Wilson. Now, you wouldn't mess with Miss Wilson. She ran that office with to a rule book, and everything was paper. But you know what? It was Dewey Decimal catalogued, and all of the paper was amazingly sort of managed. The quality of the data that's being captured in that sort of way was also pretty awesome. So that the opportunity to take a good and well managed paper-based system and make it electronic is actually, you know, one of the sort of the real sort of opportunities. And she was sort of saying, oh, when can we have it? When can we start going? And you know, that was just a joy to do that. And then we went to Kingston Hospital as well. I went around the system, the lab systems, as you know, quite often come with their own electronic systems, but essentially sort of in the emergency sort of department and you know, sort of inpatient care, there really just wasn't that joined up thing. And it's so important to be able to sort of walk the ground and to be able to know the challenges that people have. So you can see on here that we decided not to just leap in, do big bang. So we said, we'll do a proof of concept, and we'll actually sort of look at an ecosystem around sort of non-communicable diseases to start off with. They were building a healthcare app to sort of around sort of self-management, particularly around sort of chronic disease such as diabetes, and you'll get the slide. Sorry, did I click just as you were going through? And so we sort of came up with it. Now, this may seem a bit Mickey Mouse, this, but actually it's not a whizzy sort of, you know, architectural diagram. But what I like about it is it shows the component parts that we had to work with and how we would build them and where we would get to. That we are subsequently much further down the line in terms of the implementation sort of that. But it also brings to bear the practicalities of actually implementing this, you know, on a limited budget. And you can see the things that we worked out could be sort of funded from the government, what could come from the global fund. So Jamaica has to rely on sort of IDB loans, but also from the global fund. And every time they're putting in sort of grant applications in order to be able to do this. But they're so resourceful, and it was just such a joy to actually work with colleagues such as Keisha and others in order to get to this point, but actually sort of saying, you know, let's actually build on this and let's plan for success rather than actually sort of trying to boil the ocean and do everything all at once. So we've sort of, and working also with another colleague, Dr. Ian McNichol, who colleagues will know, Keisha, and another colleague, Candice, sort of worked developing sort of the archetypes specifically. And if you want to know any of the details about this, don't ask me, ask Keisha. So, but actually just building this up and looking at the scenarios, looking at the direct point of care, and actually working with a really good reference group of clinicians, both primary, secondary care, community, to actually say, what do we actually need within this, but being able to draw upon, you know, clinical knowledge manager, and also sort of building it within the archetype sort of developer. And Jamaica now has a full sort of, you know, suite of the archetypes that they've built themselves and are using them. So in terms of sort of, you know, the ref sets and constraints, you know, not everything is perfect when you're trying to do these things. So actually you can see sort of, you know, slightly different sort of starting points around sort of occupations, aligning to, you know, sort of the ISCO sort of 8 Jamaican localization, using laboratory codes from LOINC. And then we had quite a debate really as to whether we could go directly to SNOMED at sort of point of care. There was still quite a push from the sort of the clinical coding perspective, because they've always had clinical coding, to continue to sort of use ICD-10 within the record. But we were able, through discussion and development and workshopping to demonstrate that classifications have their place for, you know, sort of the statistical reporting for payment, for remuneration, but actually what you need to have within your electronic patient record is the clinical terminology, and essentially that, you know, you'd be a bit daft if that wasn't SNOMED CT. So, but, you know, this was all about a learning and a shared experience. So the decision has now been made to, you know, to use SNOMED for disease, for symptoms, for vaccination, and there was also, as I said at the beginning, you know, around the sort of identity management and developing an EMPI, actually getting even just some standardization of Jamaican addresses, sort of naming conventions, and you know, and actually recognizing how these things had been sort of built up, and being able to understand people. So why was SNOMED selected for this implementation? And I've sort of described on the left-hand side, you know, the different sort of standards and standardization. And the approach, you know, whether we're talking about semantic standards, architectural standards, interoperability, or quality standards. But actually you can see there on the right, you know, when you've got those open EHR sort of archetypes, you can then sort of deploy that in your various sort of scenarios and locations, and using SNOMED within that ecosystem allows you to build up that standardization and to actually take stuff that has already been sort of done and developed. And throughout the whole program, we called it an action series for education. So every Tuesday night, Heather would dial in from Wednesday morning in Australia, and it was afternoon in Jamaica and late evening for me in the UK. And we basically had a whole set of course sort of materials that we've sort of developed over the years within Gecko, but we were also able to sort of adapt that for the Jamaican, so it's specific to their use case. And we've basically turned a whole load of predominantly sort of junior doctors into health informaticians, and you know, I'm very, very proud of that. You know, we can't take the credit for it though, because essentially they were, you know, so engaged and so determined to actually make this work. So the final thing that I just want to run through is this sort of roadmap to national implementation. So once we did the proof of concept and we actually decided to go with an affiliate license to start off with for the shared health care record platform, SHROP, which is built in conjunction with colleagues in Brazil, Core Consulting, was actually to say, you know, if this is a success, then Jamaica can commit to becoming a full member of SNOMED without having to pay, you know, the full license fee and going, whoa, we're not going to use this. So actually we work very closely, particularly with Susie Roy and colleagues at SNOMED International, to say, can we actually sort of develop a much more incremental kind of approach, get our evidence base, and also then be able to go back to the government, to the ministers, to say, this is, you know, this is a cost-effective way, this is a good investment for your money, this is the return of investment. And you can see, I don't know whether you can read it, but you'll get the slides. But sort of in January this year, we sort of mapped out literally the to-do list to get us to the end of this year, that actually says, right, how do you set up a national release centre? Now, obviously there's the guidance from SNOMED International and you know, and some weighty tomes, but actually what does that mean in reality for, you know, for Jamaica? And so we basically said, what do we need to do in what month, at what time, what are the issues, what are the risks, and have that checklist. And that gave us a whole load of confidence that actually we were going to get there and it was achievable. We might miss, you know, we might miss the odd deadline, but actually we know that we're on this whole sort of journey and on there together. And this has been, you know, really well sort of taken forward by colleagues. And I talked a little bit about the sort of the licensing and going for an affiliate license first in terms of our approach.
We're reaching the point of questions. So
yeah, that's fine. So in summary, Jamaica now has an open EHR clinical data repository with homegrown templates using archetypes and value sets. Jamaica is the first Caribbean country to become a full member of SNOMED International. It was the 54th member, oh, no, 45th member, for, 45th member, and the Ministry of Health and Wellness has been through a full procurement for a technical partner, is now implementing that at a national level. I'd just like to acknowledge everybody who was involved, and you know, both the home and away team, and the international team, and anybody else who I haven't mentioned there. Thank you very much.
Thank you, Monica. I can say that we have started working with the Jamaican team. It's an amazing team, and they were really up to speed. And you can say that, yeah, it was a very effective job to work all these months.
Thank you.
So we are open to questions now. There's a microphone in the middle. Good.
It's just a comment. As a fellow Jamaican, I am very, very heartened to see this. Also a terminologist and a lover of SNOMED CT. Congratulations, it's an excellent start, and I wish you all the best.
Thank you very much indeed. You have a question?
Hi, my name is Mona, and I'm from Norway, and it has the same size, about the same size as Jamaica. We have implemented an EPIC system for the municipality and the specialist care in the mid region of the country, using SNOMED and using for diagnosis and the medication data. However, we are experiencing some resistance among the clinicians. Are you experiencing the same thing in Jamaica, or?
Yeah, I think so. I don't know, Keisha, do you want to answer that question? I mean, you'll need to go to the mic.
Yes.
So it's a little early in our journey. We're still doing EHR training at the moment. But what we have done is that we haven't thrown the whole browser at them. And so we've been curating value sets. And you do that on a use case basis, you know, bit of a clinical case. So it's more accessible for our clinicians. So I would want to say, you know, we haven't been getting that kind of pushback, because what we've done is made it more accessible for them.
Yeah, I think, and Keisha's absolutely right. We've sort of taken it on that incremental sort of basis, but it's sometimes you've got to say things 7 times to get the message across. So both myself and Heather and other colleagues did multiple presentations at all sort of levels. And actually it's just about, you know, not only sort of saying this is how it can be, this is what we've done so far, and being able to demonstrate it and just keep sort of chipping away and bringing the clinicians particularly into the development, so they feel that they're owning it and doing it themselves. It's not something that IT is pushing onto them, and sometimes you've just got to take your time. Yeah.
And I just wanted to add, I think one of the key things that has worked particularly well has been, it hasn't been a terminology project, it hasn't been a technology project. It's been a project to solve particular requirements for healthcare. And so the training we've done, for example, yes, there was SNOMED in the training, there was information modeling in the training, there was data quality and how you assess it across a supply chain in the training, but it was integrated. So it wasn't about somebody going, oh, I need to know SNOMED. It was all about SNOMED does this bit. You know, it was the practical use of it that was the focus. And I think that's one of the reasons we didn't get that clinical pushback, because it was about solving a clinical problem and then to say, okay, which bits of the information model do we need to solve that problem? And then which bits of SNOMED do we plug into those data elements? So very much a coordinated approach, very different to what I see in a lot of countries where the terminology sits separate and then the information model somewhere else and the messaging is somewhere else. No, this was coordinated. And I think that was the biggest proof of concept of the way to do it right.
Thank you very much. One more question.
I'm short, but I'm not that short. Well, I feel like we have done the same thing in Norway. We have definitely tried to have an approach where we haven't really focused on the SNOMED, but we have focused on how are we solving our healthcare issues for the future. And this is a tool, this is a digital tool, and the clinicians has been involved. However, I do hear that we have very different experiences. And I think that is very interesting. And I also know that if we're going to go somewhere with SNOMED, we have to have the clinicians on board. They have to have trust in that terminology. And it doesn't matter, I feel at this point, how are we explaining it? They are just resisting. And if we are the only one that are experiencing this, then we have to look at it, why we are like that. But I don't think we are the only one experiencing that. But it's about ICD-10 versus SNOMED. It's about, I don't know, really.
Sometimes it depends on the transition, where the clinicians are coming from. So sometimes there are external factors as well. All the factors that were commented today about thinking about the whole process and not only the technical parts are excellent, but sometimes are not enough. I will be keen to discuss this with you, the implementation team, and see if we can help you. Well, thank you very much. It was an excellent project.